Hello, my name is Dr. DJ Ida. I'm Executive Director of NAPIMA, the National Asian American Pacific Islander Mental Health Association. On behalf of NAPIMA and our organizing partner, Change Matrix, I'd like to welcome you to the third and final virtual roundtable in recognition of May as APA Heritage Month and Mental Health Awareness Month. Needless to say, this has been a very challenging year for our communities. We developed this roundtable series to bring together community experts who could address the rising anti-Asian hate incidences, growing mental health needs, as well as the unique and shared strengths of the Asian American, Native Hawaiian, and Pacific Islander communities. The first roundtable identified the impact of historical and present-day trauma on the mental health of Asian American, Native Hawaiian, and Pacific Islanders. The second roundtable focused on self-care and healing practices in the community. Today's roundtable, What's Next? Community Action for Transformational Change, will focus on ways we can make positive change to improve the mental health and well-being of our diverse communities. NAPIMA works closely with community-based organizations around the country and advocates for improving the mental health of AANHPIs. Over the past year, we have seen the profound impact not only on our community members, but also the burnout of service providers who are faced with the ever-growing mental health needs of AANHPIs. I look forward to today's panel, which will provide some much needed strategies on how to make positive changes in improving the quality of care for our communities. We are pleased to have Dr. Lark Wong join us today as a facilitator for today's roundtable. Dr. Wong recently retired as the director of the Office of Behavioral Health Equity and Senior Policy Advisor at the U.S. Department of Health and Human Services, Substance Abuse and Mental Health Services Administration, and many of you know this as SAMHSA. She's a licensed clinical community psychologist who has worked at the interface of policy, research, and practice in behavioral health, and her work includes reducing disparities in behavioral health, care for underserved populations, working with states and counties to improve systems of care for children and youth with mental health substance use disorders, advancing trauma-informed approaches to care recovery, and reducing the criminal juvenile justice system for individuals' mental health needs. Dr. Wong also served on the President's New Freedom Commission on Mental Health and the Carter Center for Mental Health Task Force. Lark is a dear friend for many of us. She has been a true champion, and it really is an honor and a joy to have us facilitate this. And with this, I'd like to introduce you to Dr. Rochelle Espiritu, founding partner of Change Matrix, our partner in organizing the series. Rochelle?
Thank you so much, DJ. It's a pleasure to be here with you and everyone who is joining us today. I know that we have registrants from all over the country, as well as the Pacific Islands and Hawaii, and so it's lovely to be here. Before we begin, I want to thank our partners who have been critical in supporting this three-part series during May. So I'd like to thank the Asian American Psychological Association, the National Council of Asian Pacific Americans, the Mental Health Technology Transfer Center's National Coordinating Office, as well as the Pacific Southwest Regional MHTTC, and the National TA Center on Children, Youth, and Families Mental Health. Thank you to Ricardo of the MHTTC for the logistics support, and Alice Choi of Change Matrix for sharing slides, and Dr. Sakalingam from Change Matrix, and Dr. Pamela Trivedi from the NTAC are supporting the questions and the chat box. So as you have questions, please do feel free to put those into the Q&A. That helps us monitor them, and any comments or reflections, feel free to share in the chat box. So I'd like to go over the objectives for today. We have several. First is we want to make sure we're identifying what some of those systems, issues, and policies are that are impacting access to quality care and improving the current workforce by increasing the number of AANHPI providers, including paraprofessionals. And also want to make sure we're talking about ongoing training and support for the community. We also want to clarify what constitutes culturally competent and linguistically appropriate care, including some of those innovative approaches and integrated models that recognize that relationship between physical and mental health, which is so important in our community. And then we're going to talk a little bit about who are our allies and partners and what can they do to help us in terms of thinking about systems change and what do we need to do in partnership with them. And in our lightning round question, which will be our last question of the session, we will ask our panelists to think about what are some of these bold actions that we can take to disrupt our system. So again, we do invite you to send in your questions throughout the roundtable. We will be monitoring those. And before we go into our framing that Dr. Lark Wong will provide, I want to share a welcome from Mr. Tom Kaduri, who is our Acting Assistant Secretary of Mental Health and Substance Use. And I think, Alice, that maybe when you shared, we didn't share computer audio because we're not hearing it. So maybe you can just do a quick stop share and then we will hear his message. It's still not playing, Alice. Sorry. When you do share screen, you just have to click on the share my computer sound.
Where you're joining us from. In observance of Asian Pacific American Heritage Month and Mental Health Awareness Month, I'm honored to have the opportunity to address this diverse audience of behavioral health and public health professionals, SAMHSA stakeholders, and individuals from the Asian American, Native Hawaiian, and Pacific Islander communities convened today by the National Asian American Pacific Islander Mental Health Association, Change Matrix, and their partners. As the Acting Assistant Secretary for Mental Health and Substance Use at SAMHSA, I'd like to acknowledge and invite us all to take the time to celebrate Asian American, Native Hawaiian, and Pacific Islanders, AANHPIs, who have a deep history in contributing to and shaping America. This month, there are many national and local events and opportunities highlighting the unique culture, history, and contributions of these diverse communities. I invite you to join some of these activities. As we learn and celebrate our collective accomplishments, I think it's equally important to take an honest look at how to continue to improve the quality of life for all our communities. We are indebted to individuals such as yourselves who are gathered here today to discuss such an important issue that has for far too long deserved more attention. Unfolded by the COVID-19 pandemic, there are still many challenges that our communities are facing. Last month, President Biden released a proclamation reaffirming May as Heritage Month for Asian American, Native Hawaiian, and Pacific Islanders. In the proclamation, he states, Asian American, Native Hawaiian, and Pacific Islander communities face systematic barriers to economic justice, health equity, educational attainment, and personal safety. These challenges are compounded by stark gaps in federal data, which far too often fails to reflect the diversity of AANHPI communities and the particular barriers that Native Hawaiian, Pacific Islander, Southeast Asian, and South Asian communities in the United States continue to face. At SAMHSA, we know there's work to be done, including a push for better data and disaggregated data. Asian Americans alone are the fastest growing minority population in the United States. Despite this growth, AANHPIs are often left out of our data and service programming. In terms of mental health, one of the often overlooked issues is the differences in conceptualization of mental health among AANHPI communities. Cultural beliefs and language contributed to how some communities perceive mental health issues. For example, research suggests that Asian Americans are more likely to have their mental health symptoms manifest as physical symptoms, which has implications for detection and treatment for mental illness. We also know that social stigma, shame, and lack of culturally and linguistically appropriate services often prevent many community members from talking about mental health and seeking behavioral health care when needed. Recent data from SAMHSA's 2019 National Survey on Drug Use and Health show that AANHPIs have the lowest levels of help seeking for any mental illness compared to other racial ethnic populations. Nearly 77% of the AANHPI population who had any mental illness did not seek treatment. With the recent rise in anti-Asian hate and violence, we have seen in the past year, there's no better time to come together to spotlight this important topic. On January 26, President Biden issued a memorandum condemning and combating racism, xenophobia, and intolerance against Asian Americans and Pacific Islanders in the United States. This memorandum calls for federal government to combat and prevent racism, xenophobia, and intolerance against AAPIs, including SAMHSA agencies across the Department of Health and Human Services, in coordination with the COVID-19 Health Equity Task Force, are working together to advance cultural competency, language access, and sensitivity toward AAPIs in the context of the federal COVID-19 response. While I'd like to also acknowledge SAMHSA's commitment to advancing behavioral health equity alongside this current administration, I understand SAMHSA cannot overcome these challenges without supports from our communities. SAMHSA continues to recognize the vital need for partnerships and collaboration across disciplines, sectors, and across the government. We're committed to engage with community-based organizations and members to identify and promote culturally and linguistically appropriate services and supports for behavioral health prevention, intervention, treatment, and recovery. That is why I thank you all for the kickoff of today's virtual roundtable series. This is a direct reflection of SAMHSA's support for partnerships and collaboration in order to advance behavioral health equity. Lastly, I'd like to share a few resources that SAMHSA has specifically for AANHPI communities. These resources include a dedicated webpage for AANHPIs on SAMHSA's website that includes the 2019 National Survey on Drug Use and Health, an AANHPI PowerPoint slide deck, and a report on advancing best practices in behavioral health for AANHPI boys and men. SAMHSA's Office of Behavioral Health Equity staff, who are the best, by the way, will follow up and send you these resources. I appreciate the opportunity to be part of this important dialogue. I'd like to close by quoting Dr. Mary Rory, the director of SAMHSA's Office of Behavioral Health Equity, who always says, "Together, we will get there, together." Thank you and take care.
Great, thank you. It's so nice to hear the support from our Acting Assistant Secretary at SAMHSA. And next we will have Dr. Lark Wong, who will provide context and framing for the conversation. Lark.
Okay, great. Thanks very much, Rochelle, and to Rochelle and DJ and all the partners. Thank you very much for putting this virtual roundtable together and inviting me to have the privilege of facilitating and being part of this. So I wanted to just share a few data points, a few pieces of information regarding mental health among Asian American, Native Hawaiian, Pacific Islanders. And this actually comes from the data set at SAMHSA, which I noticed on the captioning was calling SAMHSA Samsung. We are not the TV maker. We are the Substance Abuse Mental Health Service Agency in HHS. But this is one of the few studies that actually does disaggregate Asian American, Native Hawaiian, Pacific Islander data. And it also collects a large representative sample of this population, which are often underrepresented in federal surveys. But it's sobering data that they share with us, and that 1 in 7 of this population is struggling with a substance use disorder. 1 in 5 of this population have a serious mental illness. That's about 480,000 people. About 14.5% had any kind of mental illness, and 2.7 million had a substance use disorder. So we often don't talk a lot about the prevalence rates, which are high prevalence rates for mental health and substance use in this population. Next slide. This is coming from the same data set of SAMHSA, that serious mental illness among this particular population broken out by age group. And you can see that over time from 2008 to 2019, the numbers have not been going down. In fact, they have been increasing. And the highest rates of increase and the highest overall rate are 18 to 25 years old, are young people, or young emerging adolescents, emerging adults. That's striking in the sense of This is a transition time. This is a time of hope and growth, but this is the time also when we see the onset of serious mental illness in this population. Next slide. As Tom Coder mentioned, Asian Americans, Native Hawaiian Pacific Islanders seek services, access services at the lowest rate of any population group. So the rate of getting access to treatment or no access to treatment among this population was 77% of people with a mental illness and 93% of people with a substance use disorder. So think about that in terms of other kinds of diseases or disorders. Just think of people with hypertension, people with cancer. If 70% of them did not get treatment, what's going on here in our mental health system? And I don't have a slide on this, but AAPIs with substance use disorders have a higher rate of suicide attempts and completions, so that the juxtaposition or the intersection of mental health and substance use very much exists in this population as well. Next slide. So given that is kind of the baseline mental health status for this population, wanted to add on two other threats to the mental health of Asian American, Native Hawaiian, Pacific Islanders. And that is COVID first. We know that COVID has had an impact on the mental health of the population in general. And there's prediction that the next pandemic will be a mental health pandemic worldwide and a serious epidemic here within the United States as well. We already know that the anxiety from pre-pandemic to post, anxiety rates have increased by 3 times, depression by 4 times, and that 4 or 5 Asian, again, young people, that 18 to 25, 26, 4 or 5 report feeling down, depressed, and hopeless. 90% of the Asian women of that age group report those same kinds of feelings. So on top of a baseline of serious prevalence rates of mental health issues, add on the COVID issues, and I want to add one more threat to that. Next slide. And that is actually, well, before we go to the next one, this is also a deeper dive at some of this data for this population, which doesn't get into the media as much as some other population groups, that among the highest rates of illness, hospitalization, and death rates in their communities are among Pacific Islanders. And that's Pacific Islanders, both on the mainland, Pacific Islanders in Hawaii as well. For Asian Americans, there's a disproportionate burden of death among people who contract COVID-19. While the actual death numbers may be lower than other populations, they are at particularly high risk of serious hospitalizations and death if they actually contracted the virus. So the case rates and the death rates are high among Asian American. The death rates among cases of Asian Americans with COVID are high, are disproportionately high. Next slide. So in addition to COVID further exacerbating mental health issues, we have an epidemic of anti-Asian hate going on in this country. And we have different reports, particularly the Stop AAPI Hate National Report, which logs about 4,000 incidents from March 2020 to March 21. And of course, the horrendous killings in Atlanta, Georgia, including 6 women of Asian descent. We know from data from previous decades that racism, discrimination leads to and damages mental health and shortens lives. And it also points to retriggering of intergenerational trauma and historical trauma for these populations, who sometimes in their own countries of origin, as well as in the United States, have had significant histories of racialized violence. And it also says to us the burden of being a person of color in America includes the stress from the anticipation of violence and hatred and assault. And that is also, if you think about it, that is the definition of terrorism. So we have people that are now living with fears of going outside of their homes because of the burgeoning anti-Asian hate in this country connected with the COVID pandemic. So we have these additional pressures on one's mental health and well-being added to a baseline that is not well treated in terms of mental health issues for Asian Americans and Native Hawaiians and Pacific Islanders. Next slide. But we talked about here in this discussion that we really want to go bold. The system hasn't well served our population, but right now we're at an incredible window of opportunity, and perhaps a narrow window of opportunity. We have a new Biden-Harris administration that has done some remarkable work already in terms of the executive orders, and actually even working with Congress on a bill. So again, Tom Coder mentioned some of these executive orders, but I have to say that during my 35 years in the field and 15 years at SAMHSA in the federal government, I have not seen such remarkable and compelling executive orders that are naming and addressing issues for Asian Americans and Pacific Islanders. The first one on the screen really is speaking specifically about condemning and combating racism against Asian Americans and Pacific Islanders, and also calling out federal officials and national leaders who have used hate language against this population. Remarkable executive order. The Advancing Racial Equity and Support for Underserved Communities through Federal Government also calls out Asian Americans as well as other underserved populations. And this is a government-wide charge. It's a government-wide mandate to look at how you are utilizing resources, looking at your programs, who are they missing, who are they excluding, looking at your budgeting, looking at how you're doing hiring through a racial equity lens. Powerful language from an administration that has just been implemented, just been seated in less than 4 months ago. The other executive order on the COVID-19 Health Equity Task Force, I wanted to include this because this also has a public comment component to it. This is a task force, again, put together by the Biden-Harris administration to look at the disparities that have been revealed, health disparities, but even beyond just health, employment, housing, everything that contributes to health, the disparities for underserved and populations of color. And it does have public hearings and public meetings, which if you go to that link, you can see when the meetings are scheduled, and you can have input into the public comment period, which is important. And then finally, the COVID-19 Hate Crimes Act, which was passed by both the Senate and the House and signed by the President last week, speaks again and names the victims of the Atlanta, Georgia shootings, including the 6 women of Asian descent, and tasks the Attorney General to better track hate crimes, to give out grants to states, to do hate crime hotlines, to train law enforcement on recognizing hate crimes, to give communities opportunities to get grants for prevention of hate crimes as well. So a tremendous amount of work really focusing on this in the first 100 days of the Biden-Harris administration gives us a critical opening. We don't know how long this opening will last, so that's why it's really critical that we be bold and active and activist very quickly. So I wanted to just share some of that information with you as kind of a framing background for the excellent panelists that we have coming up. So let me just call your attention to them, and they will do their introductions as well. Rochelle Concepcion is the president of the Asian American Psychological Association. She's a clinical psychologist with the U.S. Army. Ed Wang is at the Department of Psychiatry, also a clinical psychiatrist, Department of Psychiatry at Harvard Medical School. Carla Thomas is, I'm sorry, it's being blocked. The captions are blocking me. She's at UCLA, I believe, Carla, right? At the Center for Research on Disparities. And
yeah,
then
She's with the Native Hawaiian and Pacific Islander Data Policy Lab at UCLA.
Okay, great, thank you.
Mhm.
And then Isha Versingwe is a senior policy associate at the Center for Law and Social Policy in Washington, D.C. So they're our panelists, and they will do further self-introductions as they speak. So we want to start off, and I should also mention their full bios are available on the NAPIMA website, which will be shared with all participants. Okay, so as you've heard from me and from Mr. Tom Coder, the mental health system as currently constructed has not always worked effectively for Asian American, Native Hawaiian, Pacific Islander communities. So our first question to the panelists is, how do we begin to rethink the mental health system? Not a small question, but we know each of our panelists has had in-depth experience working within the system. So I'm going to ask them each to introduce themselves, share their pronouns, identity, and agency and location, and begin to address this question: how do we need to rethink the mental health system? And Isha, can we start with you?
Sure. Thanks, Lark. Hi, everybody. My name's Isha Wersingha, as Lark said. I'm a senior policy analyst at CLASS, the Center for Law and Social Policy, and my pronouns are she, her, hers. My identity, my family is Sri Lankan, and I'm an immigrant. And I come to the mental health space being a caregiver for my mother who has severe mental illness. So I have been navigating the system for a very long time. So in thinking about this question, the perspective that we have at CLASP, so we're an anti-poverty organization, and we really recognized that we have a real opportunity right now with all of the opportunities that Lark had mentioned in her slides when thinking about the increase in mental health concerns through the pandemic, and also with the country's racial reckoning that happened last year. So we really we decided to bring our work together in working with people with lived experience and with all the experts that we've spoken to, and to come together to bring a set of core principles together in mental and behavioral health. So we have 6 core principles, which I'll outline for you all. So the first core principle is to redefine mental health. And that's a big principle, but it's really thinking about how we redefine mental health in focusing on wellness and prevention, and to make sure that mental and behavioral health is asset-based, not deficit-based, and that it's community-informed. The second principle is improving and expanding access to mental and behavioral health care. So at CLASP, we believe in universal healthcare coverage, but beyond that, we believe that policy solutions need to be thinking about parity enforcement, and by parity, I mean making sure that mental health services are covered at least the same level as physical health services, and that we think about mental and behavioral health holistically. As I said, CLASP is an anti-poverty organization, and we decided to focus on mental health because of all the other issues that people living with low incomes experience. On top of that, they are always mental health is at the core. And so because mental health is at the core of a person's livelihood, we have to think creatively about interventions and supports, which includes making sure that interventions and supports happen in places beyond the traditional physical health visit or the clinic. The third principle is, of course, that mental and behavioral health services need to be culturally responsive. So of course, we know about the long history of the criminalization of mental health needs and the importance of uplifting healing practices of communities of color, of AANHPIs. And we know that stigma is reinforced in our community and other communities due to our cultural norms, due to racism and discrimination. And systems need to be able to work to acknowledge these issues and work to bridge the gaps to reduce the discomfort and distrust that has existed for many communities of color to seek mental health services. The fourth principle is that mental and behavioral health care needs to focus on social needs. So when I'm talking about social needs, we're thinking beyond the social determinants of health, which is a term we use often in public health, and really think about the root causes of mental health outcomes, like racism and discrimination, like intergenerational poverty, like intergenerational trauma, but also, of course, thinking about housing and food insecurity, job security, and job quality, making sure that people feel fulfilled in their jobs, and the built environment. Because without addressing those issues, people, and from our perspective, thinking about individuals with low income, but also people of color, will continue to experience negative mental health outcomes. The fifth principle is that there needs to be quality care in all areas and comprehensive data. So we really need to be focusing on infrastructure. And so when we're talking about an infrastructure, we're definitely talking about a comprehensive data surveillance system, but we're also making sure that community data is recognized and included, and as well as data collection processes that are welcoming of communities, and that the infrastructure focuses on, is acknowledging gaps in services and works creatively and innovatively to reduce those gaps. So that means making sure that there is provider training when there are gaps, and so on. And then the last principle is that in order to make sure that mental and behavioral needs of communities are met, there needs to be an enhanced workforce. So the quality of care can be increased by diversifying the range of current and future mental health providers. So when I say diversify, of course, I'm talking about race and ethnicity, but also other identities and thinking about intersectionality. So gender identity, sexual orientation, disability, but also by broadening the definition of who is quote unquote qualified to make sure that people are reimbursed. So focusing on peer support providers, community health workers, doulas, harm reduction counselors, that they're supported, reimbursed, and that their mental health needs are supported as well. So Lark, I'm gonna stop there.
Okay, Isha, thank you very much for really sharing those critical principles and really how we can rethink our mental health system. I want to turn to Ed Wang.
Yes, here I am. My name is Ed Kwok Shi Wang, and my pronoun is he, him, and his. I'm an immigrant for many moons ago from Hong Kong, and now a proud grandfather of two lovely granddaughters. And obviously, because of them, my focus now is very much on social, emotional development and learning and behavior regulations. You know, imagine watching a 2-year-old temper tantrum. You know, how does a 2-year-old control her emotions? So with that said, I'd love to share with you my story. And so I love history. So I take stock of what we have done in Massachusetts to answer the question. And if anyone interested for more details, I have to do a shout out to Tim Wong, who was a former student, who is a former student editor at the Harvard Kennedy School. And annually they publish the Asian American Policy Forum. And he convinced me to, write an article about Asian American Pacific Islander mental health. And so I took up the task. He stayed with me and probably, shortened my articles from about 25 pages long to about 6-7 pages. So he is incredible. I don't know whether he is be part of today's webinar, but I really want to do a shout out for him. The title is A Journey of Public Stewardship on Asian American and Pacific Islander Mental Health, Massachusetts Approach to Address Disparities. So with that said, let me start with the love of history and the story of Massachusetts. What I'm going to talk about is specific game-changing events for the past 20 years, publications, blueprints, action plans that serve as the building blocks of transformation of mental health care for all. And here are some of the lessons learned that how we seized these game-changing opportunities and went to work. 20 years ago is the release of the Surgeon General Stature report on mental health, culture, race, and ethnicity. Health moved the country, I believe, from a one-size-fits-all approach to mental health care to population-specific model. And AANHPI was included. This publication was a game changer. The Office of Multicultural Affairs created a year prior to the Surgeon General report, and I was then the former, I guess, first director of the office. And I want to do a shout out for the current Secretary of Health and Human Services of the Commonwealth, Mary Lou Sutters. And I know that she is not listening in, so too bad for her, too busy for her to do other things. I have to say that because of her commitment to create this office then she was the commissioner of the Department of Mental Health, that really helped to move, the history and the journey of cultural linguistic competence forward as a mental health authority of the Commonwealth. So I began to read up again and again of Surgeon General Stature's report and operationalize the best I can in regard to what we can do in Massachusetts. And guess what? He came to Massachusetts for a very public meeting and presentation. So I used that opportunity to launch the game-changing transformation. And interesting enough, during the same year, that was the human atrocity of 9/11, etched into American psyche and history. The atrocity, though, is a game-changing event that provided us a great opportunity to put together groundbreaking community conversations, which resulted some game-changing outcomes. And I think later on in the webinar, I'm going to mention some of the examples. So for the past 20 years, I think there's a lot of game-changing publications, blueprints, like Cross the Quality Chasm, Race and Ethnicity and Language Standardizations, National Class Standards, Triple Aim, often referred to in Massachusetts healthcare reform, as well as Obamacare reformed. And I use those messages, I use those publications again and again in many statewide commissioners, managers meeting, and I think that they probably are, sick of them. But that's the way to inoculate state employees, managers. And then moving forward then, these publications became the scaffoldings of our service standards, data gathering in terms of race, ethnicity, and language. And then, of course, the important part is continual quality improvement. Then came 2013, former President Obama and former Vice President and now President Biden, the two game changers, hosted the National Conference on Mental Health. And the fact is that I also got out of that is by talking to Meryl Streep while she was one of the presenters. It was a great high point of my life to talk to an actress. No one sees a disaster is untouched by it. It happened in the same year, April 13th, we had another human atrocity, the Boston Marathon bombing. It was again the right time to bring social stigma of mental illness out of the shadow with community-wide conversations. Now, move forward is our pandemic. Our pandemic is a game-changing event and will etch into our history, along with the historical, racial trauma and inequities that we are experiencing. I wanted to reconnect with the communities like how I did after September 11th, 2001. So I created informally, I guess I'm no longer with the state government, the listening session called Wellness Under the Cloud of Racism and Anti-Asian Acts of Violence was formed. Here I want to do a shout out for my wonderful graphic designer students from RISD, Rhode Island School of Design, and he helped me to design the poster and flyer to circulate. So in conclusion, I would have to say that game-changing events and game changers continue to serve as our catalyst and momentum for mental health transformation. And I have to conclude that with what Lark said is so true. This is a critical opening, but the window is short. Thank you.
Ed, thank you very much for that historical perspective and really looking at game changers. We will look forward to hearing more about the community conversations in the later part of the panel. Carla, would you be able to go next?
Of course. Hi, everyone. Thank you again so much for having me. My name is Carla Blessing Savali Olafile Mutamis. My pronouns are she, hers. I am calling from, I'm the policy director at the Native Hawaiian and Pacific Islander Data Policy Lab at the UCLA Center for Health Policy Research. I'm calling in from the land of the Tongva and Serrano peoples, who are the original caretakers of the Inland Empire, which is based in Southern California. So this question is great. How and why do we need to rethink the mental health system? Why I think it's especially important for the Native Hawaiian and Pacific Islander population, because there's severe underutilization. In one study among Samoans and Marshallese communities, it showed that these sub-NHPI populations had rates of alcohol use disorders 3 times higher than national rates. They also had rates higher than the national average for anxiety disorders and also for major depression. In places like LA County in California, which has the second highest population of NHPIs in the US, less than 1% out of the 65,000 NHPIs in the county sought mental health treatment. And so there's really an unmet need, despite there being high mental health disparities for NHPIs. We also need to rethink it because it's extremely unaffordable, especially for the many NHPIs who are working in under the table jobs and don't receive any employer-based benefits. And also many NHPIs are ineligible for public health insurance like Medicaid, especially for migrants under the Compact of Free Association. Recently, Medicaid restoration happened in December 2020, but many states still have not implemented that. And the Center for Medicaid and Medicare Services released a presentation on how to implement it, and also provided some workaround strategies while data systems are being updated to help improve eligibility verifications for COFA migrants. And so we need to rethink all of these, the system, because of these different factors. And so how do we need to rethink it? I think from a public health perspective is that we need to think of mental health as a public health issue, which suggests that there are distal factors that cause mental health issues, and ultimately that they can be preventable with early intervention. I think that we also need to integrate mental health care into our core health system in our services, not view it as a fragmented or isolated service. And because of the way it is now, I think that people only tend to seek help when it's too late. That's what I've seen, especially for NHPI communities. So mental health checkups need to be part of our regular, health checkups and integrated into our core health system. And, as Aisha mentioned, it needs to be part of our holistic care. I think we also need to rethink the mental health system, and particularly the service delivery aspect and treatments. Like others have mentioned, it's not a one size fits all, and that each of these components of the system need to be tailored to meet the needs of the different communities impacted by mental health disparities. So mental health services and treatment, it can and it should look different for Asian Americans and Native Hawaiians and Pacific Islanders, because every cultural group within that huge umbrella has different outlooks of health and what it means to be mentally well, what support looks like in order to be mentally well. So we need to take all of those factors into account, because they can look different for Fijians, for Samoans, for Chuukese people. And that's what I have to share. So thank you so much for this time.
Carla, thank you very much. It was very important to get the perspective, which we don't often regularly get from the Pacific Island and the COFA migrants. Thank you so much. Rochelle, can we hear from you?
Yes, thanks, Dr. Huang. So my name is Dr. Rochelle Concepcion. I am a licensed clinical psychologist. I work for the U.S. Army as a civilian, and I work actually in a unique role embedded in a family medicine clinic for the U.S. Army. I also hold roles. I'm a public health officer with the Hawaii International Guard. It's important to note that my opinions are not reflective of the U.S. Army or the Hawaii International Guard. So I just wanted to make that very clear, especially in my role here today. Other roles that I hold, I also serve on the clinical committee for the Hawaii Psychological Association, as well as the ad hoc committee for colleague affairs for the American Psychological Association. So quite a few roles. I identify as a second generation Filipina American. I currently reside on Oahu, which is the land of the Kanaka Maoli here in Hawaii, but I'm originally from California, so I'm very familiar with a lot of the policies mentioned by some of my colleagues earlier. So what else can I say? I know that my peers earlier mentioned a number of different ways that we need to rethink the mental health system. So without repeating too much, I know that it's important to foot stomp some of the, the big issues, rethinking things like how we define well-being, and that's including like mental and physical health. A lot of the time within our communities, there is that strong link between physical and mental health, and it's important to, integrate that into things such as like physical health exams, or just the areas where many of the members of our communities are seeking care most frequently. Something that I have noticed just in my work is traditional psychiatric approaches are not always appropriate. They're not always a one size fits all, for members of our communities. And I'm fortunate because though I work for the U.S. Army, I have the opportunity to work with, dependents, spouses, children, and even retirees from the U.S. military, who are a diverse community in and of itself. And when I think about some of the psychiatric approaches that, I've been trained in as a clinical psychologist, they don't always fit, especially when we think about things such as cognitive therapy, psychodynamic approaches and whatnot. So trying to formulate approaches that are more conducive to the needs of the communities. And I know Carla mentioned earlier, each group has their own different mindsets, belief systems, cultural values that, affect them and how symptoms or how their concerns present. And it's very important to be mindful of those and how different they can be, and not just apply one approach to everyone. Just be very cognizant of how a person's intersecting identities can present in those clinical interventions, and cater them accordingly, just so it kind of guarantees the ability for them to continue help seeking, versus a lot of the time within the AANHPI communities, the likelihood is there's early termination of care because of a number of different reasons, such as, just beliefs that the provider doesn't understand where they're coming from, or, beliefs that this approach is not going to be particularly helpful to them because it conflicts with some of their values. I think another thing that was also mentioned is an overall umbrella consideration that representation matters. So one strategy or one recommendation is to really consider, funding recruitment and training of members of some of our respective communities. A lot of the time, folks look to their providers and they don't see somebody who looks like them. And that's really important. Somebody who looks like them, who can understand where they're coming from, is also like something vital. So it's not just providers, but it's some of the other, essential workers that they interface with, such as, as Isha mentioned, doulas, community health workers and whatnot. So considering all of these different pieces are just some of the little ways that we can ultimately achieve that mountain of like rethinking the mental health system as it pertains to our communities. And that's all I have. Thank you.
That was a lot. Thank you, Rochelle. Thank you all. I think what I heard here is that our infrastructure needs to change. We need to think about being asset-based, community-informed, use these game-changing events to reach into our communities to really reshape and hear from them. Think about what are affordable care, look at prevention, early intervention, and the importance of really a public health perspective. I want to just throw out that if we don't have voices at the table, the system is being changed. The system is being more commercialized, and CVS will be putting more counselors into their clinics where you can buy your deodorant and get your care, or Amazon will be giving 3 free sessions to all their employees. So people are stepping into the gap. So we need to think, how do we put our ideas into action? So this roundtable is about community action for change. And there are different ways people can and organizations can take action. So our next question is, what are some examples of action steps that can be taken at the local, state, or national level? So I'm going to ask each of you to address that question again. And I think I've gotten a signal that our answers need to be shorter. Is that correct, Rochelle? Am I seeing that 3 minutes?
I think we can make it up in the ally section. So
Okay.
we're good for 4 minutes per panelist on this question.
Okay, so Carla, would you like to start us off on this one?
Yeah, of course. So I love this question because I think we need to think of strategies that can help us improve equity for our communities. And starting at the national level, OMB Mandate Directive 15, which was revised in 1997, says that we need to disaggregate all of our data, and there's 5 minimum racial groups that need to be disaggregated: Asian Americans, from Native Hawaiians, and Pacific Islanders. Yet a lot of times we still see aggregated AANHPI data, and from the NHPI perspective, a lot of times isn't helpful for NHPI communities in our organizing and in our work, because we're only 1.4 million of the US inhabitants compared to over 20 million Asian Americans. So a lot of our data is hidden under the AAPI umbrella, and we need all of our local and state and county health jurisdictions to follow the OMB Mandate 15 so that we can have data to drive our work and ensure that it's evidence-based and whatnot. I think for states, like I mentioned earlier, is the COFA Medicaid restoration. We need to work on implementing that so that we have increased health coverage for our most vulnerable communities who have really severe mental health outcomes right now, and many are going untreated or undertreated. Also, for our states and national levels, we need to invest in NHPI mental health research. So if you are, a funder or a foundation, NIH, please invest in NHPI mental health research, because there's very little. I remember trying to, look into some data for NHPI mental health statistics, and it was extremely sparse, little to none. And one of the first community-based studies on NHPI communities was just published in 2019. And that's, that doesn't give us a lot to work with. So please, all of those agencies must invest in research about mental health for NHPIs. Also, I think it's mental health treatment is also, and also, the service delivery is really tied to higher education, and NHPIs have really low matriculation rates into institutions of higher ed. And so we need institutional support to increase those rates. So that can look like, if you are a student affairs professional, look into hiring an NHPI recruiter who can go into high schools and community colleges and actively bring students into college. Of course, increase outreach efforts. There might be students already and outreach and retention efforts. There are many, maybe there are like 1 to 10 of us or 20 of us there, but we need the help. And it can be really lonely being one of the only NHPI students in a really large university or even at a small college. I also think we need to invest more in our public health sector, because that's really tied to how we can engage NHPI organizations. So another group I work with is the Inland Empire Pacific Islander COVID-19 response team. And we've been working really closely with San Bernardino and Riverside County health departments. And it makes our work also limited when our public health departments are not funded adequately. At the local level, I think we also need to understand that we need to have targeted outreach to NHPI communities, which can look like reaching out directly to the existing community-based organizations. So there are tons that work on cultural immersion and bridging the gaps between our elders and passing down cultural customs to our youth. So they need to be we need to have approaches that are culturally grounded and also culturally congruent. We need to have more NHPI mental health providers, interpreters at the table, and build relationships with our local leaders and trusted messengers. So each of these, I think, are really important to creating action that can ultimately lead to better health equity for NHPIs.
Thank you, Carla. Rochelle.
I agree with a lot of what Carla mentioned. It starts with like the disaggregation of the data, because a lot of the time, as AANHPI, communities, we are all lumped in together, and no one takes into consideration what's actually happening, within those specific communities, such as like Filipinx Americans, Native Hawaiians, Pacific Islanders. So I think it's really important to, just highlight what are the specific things that are going on with those communities, and, disseminate funding, to support some of those key issues that are being identified. Though I can't really like break everything down at a local, state, or national level, but some of the things that I made note of when I was pondering this topic is, just having dialogues with officials in your local, county, and state level. So for example, getting involved with your local professional organizations and seeing if you can be part of a legislative action committee that's embedded as in part of that professional organization, who much of the time they usually have like the FaceTime with some of the officials. So for example, for the Hawaii Psychological Association, we had opportunities to sit down with representatives from our Senate and congresspersons' offices to express concerns about, some of the very things that we're talking about today, just how do we get more, folks from the respective populations trained up and serving our communities that are in need of them the most. Thinking about other action steps you can take. Not everyone is made to be, that protester that's like, marching outside on the street. So think about the smaller things you can do. Amplify voices, use your social media or your media presence as a way to, amplify some of the issues that are affecting us. So you can spread the education about what are the needs, or what are those ways that we can, help our communities the most. Let's see. And then just if you are a researcher, finding ways to collaborate with others. I think Carla was part of a local COVID-19 research cohort, but there are other like research cohorts that, you know, cover like larger organizations and even specific communities. You know, the Asian American Psychological Association is also involved in a COVID-19 needs assessment survey and provided some, you know, vital information about how COVID-19 and even some of the racism that's affected our communities impacts those, and generated some recommendations based on some of the results of that needs assessment survey. So just overall thinking about, you know, outside of the box in terms of like, how can you amplify your voice, and, you know, what is the most reasonable way for you to get involved, you know, even at the smallest level. And then, you know, if it can make larger waves, if you think about, you know, continuing to engage in some of those actions. So that's all I have. Thank you.
Great. Thank you, Rochelle. Ed.
Hello, everyone. Just to kind of follow up with what everyone said and before me. And first of all, I will give some examples again, in terms of the State Mental Health Authority, in terms of some of the action steps and activities. I provided a link to the Cultural Competence Action Plan, an old one. It's accessible online, and you can actually even go into the weeds of all the action steps by examples and so forth. And I think that's a fiscal year in Massachusetts. What I'm going to talk about very quickly is regard to the Cultural Competence Action Plan of the State Mental Health Authority, looking at both in terms of the leadership structure as well as the domains of Cultural Competence Action Plan. So in regard to the plan itself, it has how many domains? 6 domains, I believe, 6 domains. The first one is community partnership. We talk a lot about, you know, community partnership, both mental health providers as well as non-mental health providers, because we really truly believe in order to have a whole person that we need to look at. I think that Carla was saying earlier, is that mental health is not an isolated services. It is a wrapped around of many type of services of a community can embrace those that are, you know, impacting by mental illness. So, so one of the domain we have is community partnership. The next domain is services, which focus in terms of standards and quality improvement. Many of you already mentioned data. And then we actually have a research component. We have 2 centers of excellence in Massachusetts, and each of them, we actually created a position specifically in regard to multicultural research. And then we have the training components as well as information dissemination. A lot of times, even in our small state of, you know, Massachusetts, sometimes the left hand doesn't know what the right hand is doing. So I think information dissemination is very critical. So that's constitute the Cultural Competence Action Plan. Then what we did is we looking at what's the structure that we need is to provide that leaderships and oversight as well as, you know, doing the work. So first of all, I mentioned the Office of Multicultural Affairs. So that's basically the 6 domains is the domains of my office, my office, you know, the former director. And then we have the Multicultural Advisory Committee, which is really consisting of external gatekeepers that really try, in many ways, we try to be honest in terms of what we are doing well and what we are not doing well. And they keep us, you know, on our toes. We have an internal called Cultural Competence Action Team. These are senior managers across 6 areas. Then when I first started, I think they reduced to 3 main areas now in Massachusetts. And, you know, we want to keep them on their toes in regard to, you know, service procurement, design of the development of the request for proposal, and of course, continuous quality improvement. And then we have the State Planning Council. And the key part of it is that I wanted to establish a relationship so that the State Planning Council will include, you know, people of diversity, which we able to push forward with the co-chairs, the 2 chairs of the Multicultural Advisory Committee to be part of the State Planning Council. And then we have actually, for the last several years, we developed something called Behavioral Health Disparities Operations Team. This is wonderful. This was a wonderful experience because I was able to work across all the children's services agencies, state agency in Massachusetts, because we all participated with a SAMHSA funded project on disparities. And our focus is on data collection, setting the standards of data, and also in terms of implementing how to collect the data. And then finally, we have another structure called the Children's Behavioral Health Disparities Initiative. And then for that, we also push forward and advocate for a disparities committee. And so, is my time's up? I can stop.
Okay, thank you very much, Ed. It sounds like the beginnings of an infrastructure grant. Really nice.
Love to see that. Love to see that.
Yes.
For our community, yes.
Okay, Isha, can you wrap this question up for us?
Sure, Lark, thanks. I agree with the suggestions that Carla and Rochelle and Ed had promoted, and definitely ditto to the disaggregated data piece, because without disaggregated data, we can't push anything forward. So on the local level, I think one way to think about action steps is to think about models that work for specific communities, as Carla was talking about, and then connecting with legislators on the local level. You can always get discretionary dollars to help sustain those models, at least for the short term, and then you can think about building that up and scaling it up. There could be better connections, between agency officials and legislators and people with lived experience. And something that we had done at CLASP is to get state agencies to build community-based advisory boards. But if you are on the community level, you could push your state agencies to do the same. I'm a big fan of coalitions. I come from a lot of coalition building in my past, and I think they hold a lot of power to mobilize, even if they're not formal, to push legislation through or to push other pieces that you want to push through, to even highlight what's working for your community. And this is not so exciting, but even you can think about policy level that's not, or policy pushes that aren't beyond legislation or resolutions, and really focus on regulations. So something that we did with our partners in Prince George's County, Maryland, was they recognized that the young people living in their county really wanted to focus on text-based therapy. That was the way that they felt like they could really connect to check on their wellness. And so we were working with the county to push on the state level to change things on the regulatory side, which included, doing some advocacy in writing a letter to the governor and making sure that the text-based therapy was reimbursed. And anybody can do something like that. It's not something that an advocacy organization needs to do. And another thing on the state level that I feel very strongly about, and I alluded to in the beginning, is to think about how states have their scope of practice laws, like who gets reimbursed for services, and those scope of practice laws in many cases need to be expanded, along with definitions of medical necessity and what is defined as being able to be reimbursed. And communities can push to make sure that, and to push on the state level to expand those scope of practice guidelines. And then the last thing I'll say on the federal level is a nod to one of the things that Lark had mentioned in her initial slides, is that RFI and racial equity, there's a section in there that is specifically focusing on how communities can be funded. So, and that RFI is open to everybody to comment on. So I really encourage you all to talk about, how can communities get funding directly? How can different communities of color be funded? And also push beyond evidence-based practices. I know we talk about that a lot in this space, but thinking about what practices work for different communities that don't actually have the title of being evidence-based, because they work for very small communities and they haven't had the ability to get the data that they need to make them evidence-based. So I'll stop there, Lark. Thank you.
Okay, thank you. You all had so many great examples, ideas. I don't know that I can summarize all of them, but certainly a couple of key things that came out were really disaggregating data really within the AANHPI populations, workforce issues, getting people in the pipeline, doing culturally developed and culturally engaging outreach for workforce development and pipeline issues, amplifying voices, using social media to amplify voices. Relationships seem to be at the core of a lot of these things as well, in terms of relationships with state legislators. And again, I think people want to know what to do. I think states, given what's been revealed by COVID, and the real harsh, striking disparities across population groups, states want to know, well, what am I supposed to do? I think now is an important time to link up with those state agencies or respond to requests for information or do Hill visits or state capitol visits to say, this is what you can do and this is what has worked in our community. I think there'll be more response in this short window of opportunity we have now with government leaders who are making decisions about how to disperse funds, how much to do, and what strategies and for putting out critical funding. So a lot of infrastructure kind of building ideas. Let's go to the third question. So recognizing that advocacy and policy can be challenging, and thinking about unexpected partners and voices with power, who is not at the table. You've all mentioned different state agencies, state governance committees, as well as community-based organizations who are missing and not at the decision-making table. In what ways can you engage allies and partners in this work? So in what ways can you recommend engaging allies and partners in this work that we're doing? Isha, why don't we start with you?
Lark, so we've been really wrestling with this question lately at my organization at CLASP. And my team has been doing this for a couple years, but in terms of bringing it to scale, we strongly believe in bringing people with lived experience to the table. But the ways in which we do that we need to make sure that people are respected in the space. So making sure that people are adequately paid, that we are thinking about that people are coming when they are available, that we're not trying to make sure that people fit into our 9-to-5, schedule, and that we make sure that people with lived experience or people come at their own comfort, and that we are there to help them understand policy if they don't understand policy, or if they do, we are equal partners in this. And so one way we've been doing that is an effort we call a New Deal for Youth, in which we have brought 39 young people from ages 14 to 30 to bring their policy ideas, what they want to see in what we call a New Deal, specifically for young people. And we had a big our public launch yesterday, and on that link that was just posted, thank you for posting that, you could see the recording. But on there, it's really trying to make sure that young people are leading in this effort, and we as a policy organization are helping them. You know, if they have an idea, we think, okay, these are the potential strategies you could use, but we're not leading the work, they're leading the work. And in that effort, one of the areas that they wanted to focus on is healing and well-being. And when they think about healing and well-being, it's really thinking about it broadly. So I'll just say that they are really helping us, and we're learning a lot from them along the way, and it has been an incredible experience.
Great, thanks. And I really recommend people go to that site. Isha, I did have a chance to look at your new deal for youth, and it's very exciting work. Ed?
I just want to share with a very unexpected outcome. I mentioned about, the September 11th community conversations. And then I think subsequently, we also have the Boston bombing marathon bombing conversation as well. But the really unexpected outcome is that what we have done, with actually the SAMHSA support for 2 years, we were able to generate an ongoing community conversations. As a matter of fact, the bottom line is that after the funding stopped at different times, those participated in our conversation, they continue to kind of ask me, say, oh, when is our next conversation? But the very heartwarming, but it's also a very difficult journey, is that because of the community conversations and based on their definitions of mental health, what's the impact of September 11 on the community? There's no mental health terms being used. They designed it, they developed, what their community engagement process is going to be and so forth. 20 ethnic organizations, including 4 Asian American organizations, participated. And very interesting enough is that the outcome of that is that some eventually became subcontractors with the Department of Mental Health, because that opens the door for an opportunity for them. And several of them, as a matter of fact, ended up to be sole contractors to providing community rehab support services, for the Asian populations, residential program. I never expected that would happen because of the community conversation.
Great, thank you for sharing that, Ed. Carla?
Yeah. I think that there are tons of ways that we can engage our allies and partners. First is just by finding common ground in our issues and our interests, because a lot of times we're not that different from what our struggles are and our challenges, because we are, under the same system that oppresses our communities. So for example, in my COVID work, it was extremely hard for us to find COVID-19 testing sites for our NHPI communities. We looked to our African American communities to help us find sites that we could host testing at for for NHPIs in the Inland Empire. So things like that, understanding that there are similarities and commonalities between each of our challenges, and that they can bring us together, and that ultimately a lot of our work, we have the same end goal, is improving and increasing equity for our communities. I also think it's important to educate our allies, especially speaking for the NHPI community. I feel like every space I go into, I have to do NHPI 101 on who Pacific Islanders are, what our cultures are like, who are our people, because not many people really know. So I think that, that piece is super important. Advocacy, of course, especially when, when it comes to data, reaching out to our epidemiologists, our biostatisticians, our data IT groups, and talking about the importance of having NHPI data as its own group and its own, recognized as its own racial group, rather than clumped with the AANHPI umbrella or listed as other, or not even reported at all, which I'm seeing with a lot of COVID vaccine data, especially. So I think that those pieces are really important, even though a lot of the pushback is saying, you know, we need to suppress data for confidentiality reasons or something like that, we're always going to have small numbers for NHPIs. There's only 1 million, over 1 million of us. So our numbers are always going to be small, and suppressing that data and hiding it for those reasons, you know, takes away the work that can possibly be done to prevent sicknesses and deaths in our community. And of course, it's important to maintain consistent relationships with our stakeholders, especially our public health departments, who can help us improve mental health outcomes for NHPI communities. And so, you know, not being afraid to ask for support. You know, we need funding to help our work, because a lot of CBOs do, especially for NHPI community organizing, a lot of it's out of pocket, and they work 9 to 5 jobs as well, and they're still doing community work as, you know, as what their true passion is, but it's not helping them make ends meet. So having those relationships with those allies and partners are really crucial. But in total, I think finding common ground with other communities helps us to build a united front, and engaging all those stakeholders and helping them educate on who we are and understanding our struggles.
Thank you. And Rochelle, let you wrap up this question.
I think a really big part of what hasn't been mentioned yet is like continuing to engage with, you know, potential collaborators, even, you know, other allies that don't identify as, you know, AANHPI. So like one example I can give is some of the work that has been done with regards to COVID-19 within the AANHPI community. It's a collaboration of different organizations and agencies, and includes like researchers from different disciplines, and, you know, them amplifying their voices using their data in order to, you know, really put out the information about what's missing within our communities, and advocating to our, you know, leaders what's needed, you know, to better support our communities. So I think that that's really important. Other things is, you know, just pay attention, keep your ear to the wind with what's happening in the local communities. You know, pay attention to what's happening with like some of the organizations, and see how you can help out, whether it be amplify, you know, their missions in one way, support them by either volunteering or, you know, offering to assist in some way. There's always a need. And I think that much of the time when you're cognizant of what's needed and you can fill that gap, that's one way to, you know, just continue building like those partnerships. I think that much of the time, you know, when we think about our communities, we've always been stereotyped to be, you know, the silent minority, but at the same time, there's so many, when we, you know, just put all of our different communities together, that, you know, our voices can ultimately be amplified in order to, you know, continue doing the work. So I would say just find some of those opportunities and see where you can fit in, you know, just as an individual, or even if you're representing a specific organization, you know, see if there are some ways that your organization can support another organization and whatnot. So hopefully that helped, but that's all I have to say.
Okay, great. So, so I think we heard a lot about coalition building, about hearing from people with lived experience, people from the community conversations, educating our own communities as well as communities outside of our own communities about who we are. It makes me think about the what people talk about as the empathy gap, that people don't really care about other communities or care about a community here or there, or as Carla said, a small community. But without addressing and doing something about that empathy gap, we won't get political will to bring about change. So I think a lot of the things that you're all saying fit into that concept of the empathy gap, and really starting at the voices of underserved populations or unheard populations. We don't always do that. We start with the majority population, and then we kind of weave out and try to adapt whatever our thinking should be. We don't start at the endpoints. We don't start at the margins. We don't start with the people whose voices are not routinely heard. And I heard that a lot in the allies that you're talking about as well as how do you ally with the privileged populations, with the populations who are controlling the budgets and the decision making and the pipeline and the mental health system, which was not ever developed as a system of equity. We know that who accesses it and the routes through it are very different by different population groups. So thanks for all your comments on this third question as well. So I think I'm going to turn it over to Rochelle.
Yeah.
Now for the winding us up and doing questions or comments.
I am. Unfortunately, I think we're not going to have as much time for the Q&A, but we did have 3 questions that our panelists have seen and have agreed to provide some written response to. So we will make sure that we provide that in our follow-up to you, because they are good questions. We want to make sure we provide some context for them. So we're going to go ahead and quickly move into our lightning round question with our panelists. I do want to request that before we do that, I do want to request that you complete a brief survey about our roundtable today so that we can continue to provide these kind of offerings to the audience. And so that will be in your chat box. We will post that link in there, and your information is really helpful to us. So we titled this this roundtable series, "It's Time for Bold Action." And so we'd like to end with a lightning round question to leave participants with some bold ideas. So our final lightning round question to the panelists is, how can we disrupt the system to improve the mental health of AANHPI communities? And so I'll start off first with Ed.
Disrupt the current system with your current allies and partners, but make sure that you continue to expand who they are. And I would suggest to use a social capital model that focuses on strengths of a community to provide both a framework of community discussions as well as moving towards equity.
Thank you, Ed. Isha.
Thanks, Rochelle. Tell your stories, although it can be really exhausting to tell them over and over. And like Carla was saying, to do a one-on-one all the time. It's important to, the more people who are telling stories like Carla, the easier it is for all of us. So it's only when we speak truth that people are going to listen, and we really have an opportunity right now where people are listening.
Great, thank you, Isha. And Carla.
Thank you. So because the NHPI community is a really small population in the US, I really need everyone's help to help us demand equity for NHPIs. And although, you know, there are a lot of AAPI spaces, AAPI doesn't always mean that there's a PI at the table. And so we need to challenge inclusivity in any space you're in any committee, any meetings, any movements about equity, health, immigration, education. Please ask, where are the NHPIs at the table? And if there aren't any, then ask why, and how can we include more NHPIs to be included in the conversation, because we are, you know, often left out, but, you know, we need to be part of those conversations. So please help us demand for equity by challenging inclusivity. And I ask that people care, because, you know, although we're not often seen a lot in the community every day, day to day, a lot of, you know, the American culture is intertwined with PI culture nowadays, where people, it's graduation season, we see people wearing leis, we see people having luau celebrations, and people love football in America, and we have tons of Samoans and other Pacific Islanders in that industry as well. So yeah, think of us in all the spaces that you're involved in, and thank you so much for having me.
Thank you, Carla, for that reminder. And Rochelle.
I was actually thinking of the same thing that Carla put out there, is like, find those spaces at the table where it's lacking, you know, representation, right? At the beginning, I mentioned representation really does matter. So, you know, when you think about some of those larger spaces where your voices can be amplified, you know, think about finding a seat at that table. And if you're, you know, if there is not a seat for you, find a way to create your own table so that, you know, we can continue to amplify our voices together. Right. And think about, just like Carla said, think about including, you know, others. If you see that somebody's not in that seat, you know, ask about it, find somebody who can fill that seat so that everybody is equally represented and everybody's voices can, come together and amplify.
Great, thank you, Rochelle. And finally from Lark.
Oh, I said that I didn't need to take time for this, but since you're showing my slide, I'll just say that think about activism and advocacy also as a form of self-care. And we learned that at the virtual roundtable Rochelle and DJ did earlier this month. Build on your skill sets. People have amazing skill sets they don't realize that are very critical in being change agents or activism. We have a set of chefs that are doing AAPI chefs against API hate. Center at the margins, which I mentioned before. Deploy your partnerships also across different social influencers and among privileged. And the empathy gap is something I think that we really need to pay more attention to. I think that has to do with stories, has to do with education, has to do with really building coalitions across different groups to garner political will.
Thank you. Thank you. Amazing, amazing conversation. I'm going to turn it over to DJ to close us out quickly.
Thank you. First of all, thank you, Lark, and the panels for sharing your words of wisdom and for really giving important information on how we can make transformational change. We started this series on May 10th with historical announcements made by Congressman Judy Chu proclaiming May 10th, 2021 as National Asian American Native Hawaiian Pacific Islander Mental Health Awareness Day. And we ended the series with a message of strong support from Mr. Tom Kodera, Acting Assistant Secretary of Mental Health, Substance Use. And we're grateful for their commitment to reducing health disparities and improving the mental health of AANHPIs. Over the course of the 3 roundtables, we heard from experts representing the many facets of AANHPI communities, and we heard from you as well as community members. We learned and shared much, but there's still so much more that needs to be done, and together we can make true change. So I invite you to share with us things that you are doing to improve the mental health and well-being of all of our communities. And again, NAPIMA and Change Matrix would like to acknowledge and thank all the panelists, speakers, and our partners for making this roundtable series a success. And most importantly, we'd like to thank you for joining us and being part of this journey. Take care, be safe, and stay healthy.